All right. Hello, everybody. Well, today I have the pleasure of introducing Dr. Julian, who will be talking to us about implementing motivational interviewing in the care of diabetes. Dr. Julian is originally from Ohio. He went to medical school at Ohio University Heritage College of Osteopathic Medicine. He joined the University of Louisville, Norm Children's Hospital, for his pediatric residency, and then we were lucky to keep him here as one of our amazing fellows. So, everybody, okay, here is Dr. Julian.
Thank you, Dr. Cabrera. So I'll be talking about motivational interviewing, a lot more time on the motivational interviewing piece and kind of how we tie it into taking care of diabetes. To start out, I want to ask you all just a few quick, easy questions. All you got to do is raise your hand. And so starting out, who all likes being told what to do? Yeah, it's not very fun just being told. And now thinking back, when you were a teenager, how much did you really like being told what to do? Raise your hand if you thought that was a good thing. All right. How about if you had a teacher, coach, parent, and they went on this like long soapbox lecture, just telling you all the problems in your life and how you can fix it? Did it work for you? Go ahead and raise your hand. Not seeing a lot of hands. Nobody's raised them really seriously so far. Okay. And then how about when you start doing this to your patients, do you ever notice they start to roll their eyes, they start to cross their arms, they seem to just check out, stop paying attention? Do you feel like you're really making that connection there? No, that doesn't really work. So what do you do then to connect with them? So motivational interviewing is meant to be that tool to help you meet that patient and connect with them a little more. So our learning objectives then are to define motivational interviewing. What is it? Understand what the stages of change are, how those relate to motivational interviewing, how we use those together. And we're going to look at opportunities to use motivational interviewing in diabetes treatment. And then we're going to try to understand some of the benefits of using MI in diabetes treatment. I don't have anything to disclose, no conflicts of interest or financial conflicts. And parts of this presentation were produced with AI. So, introduction to motivational interviewing. It's really about understanding the spirit, purpose, and connection to the stages of change. That we want to get into where are these people, what are they interested in, what's important, and how do we help guide them through to what is important. It's collaborative, it's person-centered, it's a form of guiding to elicit and strengthen motivation to change. It's been around since the 80s. It was first introduced and used to help with addiction. Since then, it's been applied to lots of other parts of medicine and ways that it's helped improve healthcare, really focusing on exploring and resolving ambivalence, and kind of the tagline to it is rolling with resistance. To be a little more strict in our definition, so the APA has motivational interviewing is a directive, client-centered counseling style for eliciting behavior change by helping patients explore and resolve ambivalence. It emphasizes autonomy, collaboration, and evocation. And so there's 4 main elements we'll get into a bit. First is our partnership, side-by-side collaboration of our expertise and the patient's expertise. We are experts, becoming experts in endocrine and continuing to grow in that experience. And they are experts in who they are, who their families are, what their life is. So we're trying to partner with them of what their day-to-day looks like, what is their life carrying out as, and we're using our expertise of what medicines are available, what technology is available, and how do we help to bring those together to be used for their care. The second element is acceptance. So just as they're experts in their lives, we have to accept who they are, that we aren't going to change them, but rather they want to change themselves. So we have to accept who they are. We have to keep empathic and non-judgmental attitude, accepting where they are, respect them and their current situation. So, as we're talking about counseling, changes, accepting that right now you don't have the money or access to a gym. And so telling you to go work out every day in the middle of winter without a gym, how realistic is that? That's not accepting of their circumstances. But then talking through those parts and understanding, so partnering, accepting, understanding, and having compassion to that. So, it's all well and good to ask about it and to hear about it, but then having compassion to it and trying to promote their health without doing harm. So asking about those barriers, those parts that make life difficult, how come there's this disconnect, and doing it without being harmful in that way, making them feel called out or offending them, and trying to help find changes that the patient finds important. So, when we're doing lifestyle coaching, we have a lot of different things we can talk about. We can talk about exercise, we can talk about sugary drinks, we can talk about foods, we can talk about time of day to eat, and all of it can be important, but what's most important to them? And so talking through those parts of what is their thing they want to work on. And then the last element would be empowerment. So we've identified stuff, we've accepted them, we've worked through it, and we want to empower them. So keeping patient autonomy. We're not trying to impart our plans for them, but rather we want to raise up the patient towards their change. We're utilizing their values, their motivations, and we got to help them find those. All right, so what's the purpose then of this? Help individuals find their own motivation for change, build intrinsic motivation and not impose our own external pressures. And it's useful for addressing addiction, health behaviors, and adherence issues. All stuff that comes with diabetes care. We have all different parts of this in what we do. So kind of coming back to a line that was earlier before the elements, but drawing it out a little more with some emphasis, here's the spirit of MI. So it's collaborative. We're working with that person, not on them, not at them, that evocation. So we're trying to draw out the person's own reasons for change. I feel like we've probably all met people who've smoked at some point in their life and then said, you know what, when my first child was born, my first grandchild was born, I decided I need to quit. They had their own reasons. We need to evoke that. We need to find what is that reason that's going to help you on that journey. Autonomy, so respecting the individual's right and capacity to choose. So I can't make anybody do anything. I make suggestions. I have my expertise. And so letting them choose what is important, what changes they want to make. So the skills to do this. So we have defined MI a little more, and now we got to understand how we're going to try to apply it. So some core skills to it, starting out with open-ended questions that we can't guide to change. We can't find places for change without understanding where we are. So open-ended questions. What do you feel is most important about making changes in lifestyle? What do you feel like is an area you want to work on? What do you feel like has been challenging lately? And so leaving a lot of these spaces for people to talk rather than, do you exercise? That's a yes, no. That doesn't really open up a lot of conversation. That shuts it down. And then they're going to want to say yes because they know that's the right answer, and then doesn't really give you a lot of room to talk. So affirmations. So what do you like to do to help you move? And they say, well, you know what? I have a really busy schedule. I just haven't had time for it. That sounds really tough. Sounds like you've had a lot of time taken up with other stuff. What do you think might help you balance some of that time? So you're affirming it and you're reflectively listening. You're turning that statement that they gave you back to them, summarized, and they feel seen, they feel heard. When we have troubles in our lives, do we want people to just turn around and fix it, or we want somebody to hear us? What do you guys think? Do you like to be heard? Do you like to problem solve, get it done with? Yeah, we want to be heard. We want to know that somebody's paying attention. We want to know somebody's caring. And then we're summarizing that at the end. So as the visit's wrapping up, we're going to reflect back on some of those things they shared with us. We're going to affirm some of those things. And these build rapport. They guide the person towards that change talk. So as we're talking about exercise, you have this busy schedule, and they're like, you know what? As we're talking about this, I do have some time here. Maybe I can squeeze in this here. And we're guiding them towards that, or at least finding that motivation if I do want to exercise more. And so we're getting towards that. And that's something called change talk. So there's two main types of talk when we're thinking of MI. There's sustained talk and change talk. So change talk are statements that indicate desire, ability, reasons, or need for change. So I want to start exercising more. it's a great place to start from. We're working towards the same goal. And again, it's not going to look exactly the same of what I have in mind versus what they have in mind. That's okay. And the goal then is to elicit and reinforce that change talk while reducing sustained talk. One of the things that can be a little tricky in sustained talk as we get into it is sustained talk is not the same as discussing barriers, right? Because we do need to discuss barriers that when we're talking about, I'm too busy to exercise, we need to talk about, well, what are some of those things that fill up your schedule? How do we help to accommodate, fill it in, add it to? And that's using those barriers to help find a solution with the patient rather than sustained talk would be drinking helps me relax. And so a good example response to I want to start exercising more, what would be different if you exercise more? And that would give them the chance to share, when I go play with my grandchild, I keep up, I don't feel out of breath, I have more fun with it. When I'm walking with somebody and we take the stairs, I can continue that conversation. Or again, like when we're talking about the smoking, my child was just born, my grandchild was just born, and I want to be there for them. And so finding these reasons that give them the power, the reason, the drive to want to make these changes. So then we'll talk a little more on sustained talk later, but since I brought it up, any language that a person uses to express reasons for maintaining their current behavior, status quo, or not changing. It's the opposite of change talk. And so again, that drinking helps me relax. I've tried to quit before and it just didn't work. All right, so our stages of change then, because it's a continuum, it's not just everybody's ready to go right now, let's change, I'm going to be a brand new me. So pre-contemplative, they don't even know they want to change. They're not ready to talk about it. They haven't talked about it before. They hadn't even thought of it. It's the first day they just picked up smoking. They're not thinking about quitting. So we're not quite there to change talk yet. But bringing up the conversation in a capacity that's not confrontational maybe helps bring them to two. That contemplation. They're kind of like, maybe I will, maybe I won't. Not so sure. Could be interested. Tell me more. 3, preparation. So they're actually like, you know what? I want to do this. But what does that look like? How do I get there? All right. That is really the time to capture MI. Like that's when it works the best, is that planning for change, because you can be really just a sounding board, a bouncing point for them to help figure out what's going to work, how to help it stick. 4 is that action. So implementing change. So they're going through the process, and now MI, we're using what worked, what didn't work, how can we adjust, how can we reset? And 5 is that maintenance, that sustained change. So helping them continue to find reasons to continue to emphasize that purpose and why they want to change. So relating it then, it encourages awareness in that pre-contemplation. It resolves the ambivalence in contemplation, help to build confidence, commitment and preparation and action, and supports self-efficacy and maintenance. So, we feel a lot more obligated to do something or willing to do something when we've talked about it with somebody and we've kind of made ourselves accountable. And so as we're talking them through these changes, supporting them, helping them find what it is important, it kind of is building their own accountability to it because they've said it to somebody else. Like, I want to make these changes. They've heard them say it. So now putting it in practice. Used in a lot of places. It's used in healthcare, for counseling and therapy, in education, and in corrections. Supporting medication adherence, lifestyle changes, sounds kind of like stuff we do, and focuses on empathy, acceptance, and empowerment. Again, those 4 elements or core pieces that we've really gone through a lot here. So again, some sample dialogue of starting out with open-ended question. What concerns you most about your current habits? Give the patient a lot of space to talk about what's important to them, explores their point that they're thinking about, what change might be good there. And I know I should exercise more, but I never have time. And so now we're going to be reflective. We're going to be affirming. It sounds like you are busy, but you also see reasons to make time. So we're supporting that change talk. We're trying to build that, why do you want to change? Why is it important? And again, creating that own self-motivation to it. And you're reflective and evocative. So you're going to continue on encouraging statements that express desire, ability, reasons, or need for change. So I want to get my A1C under control. Most people feel that way. And I don't meet a lot of people with diabetes that say, you know what, I wish I could feel worse. They all want to feel better. And so then again, like what would make you feel better? What feels important? What do you think would help bring down that A1C? Where do you feel like you're having a challenge? And so you're looking to those barriers there. And a lot of these, that's that finding the difference between sustained talk and barriers is what's challenging. Well, okay, how can we change it? And then you're turning it into that change talk to help empower them. So sustained talk is reflecting on reasons not to change. So a barrier could be, I'm really busy. I don't have time to check my blood sugar before I get to lunch because I go straight from class to lunch, or I always have meetings in the mornings and they go right up to lunch and I don't have time to check my blood sugar. Well, what would be a reason that you feel like you should start checking your blood sugar? Do you feel like you go high a lot in the afternoons? Do you feel like you have a lot of lows in the afternoon? How does that affect you sitting through tests or then getting work done in the afternoon? And thinking about those important motivations to them. And so, all right, well, we found a barrier. And rather than just saying, I'm too busy, I can't do it, it's, well, what does that day look like? What would be the best outcome if you made this change? And so it helps them to focus on what can be. So some of those pitfalls is just arguing or persuading. They say, I can't check my blood sugar before lunch. You say, yes, you can. All right, they suddenly are going to do it. Now we fixed it. It's over. Giving unsolicited advice. So, I can't check my blood sugar before lunch. Well, if you don't check your blood sugar before lunch, your kidneys are going to fail you in your 20s. Okay, that really worked. They're listening now. All that does, you're just going to make them angry at you. So ignoring ambivalence. So they say, I feel like I should exercise more. And you're just like, all right, they're aware, and then move on. Support them in that. And then failing to reflect or summarize. So again, you guys told me that you like to be heard, you like to be seen. So doing that same thing for your patients, that chances are if you like that, they probably do too. They're humans. We all like to be seen, like to be heard. All right, so it's evidence-based. It's not just a good idea. It's been being used since the 80s. It has strong evidence in addiction treatment, chronic disease management, and behavioral health. It increases engagement and long-term adherence. All right, so summarizing MI a little bit before we get into some more of the diabetes specific stuff. Empathy, collaboration, autonomy. Eliciting change talk, not imposing change, not telling people what to do. And it supports movement through the stages of change model. So why use it in diabetes care? Well, we said we use it in chronic disease. We use it in lifestyle modifications. Sounds a lot like diabetes. And it requires sustained lifestyle changes. There's a lot of ambivalence about behavioral changes that, we all kind of know what we should do, and then we live somewhere kind of nearby that, or maybe further away. And MI helps clinicians address these, really enhance that intrinsic motivation. So getting the patient to want to change for their own reasons. Because some of the common challenges in diabetes is resistance to lifestyle changes. They aren't in a place where they want to make these changes. They're a kid with parents who buy the groceries for them and they can't make the changes. So you're also working with the parents. Or you're talking to somebody who's 50, 60 years old and who's buying the same groceries they've been buying for 30 years. They've got a little resistance built up over that. They've got emotional fatigue or burnout that, again, listening, hearing, understanding where they are, that what's life look like right now? Are you working 2 jobs, barely making rent, barely surviving? Okay, maybe right now is not the time to focus on trying to add an hour of exercise every day, but let's focus on which foods you do get to eat in the day and what times you're eating. And so that low self-efficacy because they've spent years being told they're doing a bad job, their A1C is too high, they're not good at this, and they've bought into it, they believe it, and they say the same things themselves. They just don't believe in themselves anymore. Information overload, we've been giving tons of information. It's really helpful. The CGMs are awesome, but they spend all this time looking at how high their blood sugar is, and they're like, I just can't even think about it anymore. It's too much. I don't know what I'm going to do about it. This is the way it always is. And it provides a framework to navigate these barriers empathetically. that we're not just trying to bring up these numbers or these problems or these challenges because, hey, this is your fault, fix it. But bringing it up of what can we do? So again, discussing the glucose monitoring non-judgmentally. Explore those barriers. What makes checking your blood sugars difficult? Are you going straight from meetings and just eating as fast as you can in between? Are you between classes and you're not allowed to have your phone, even though you have a 504 and you're supposed to have your phone? What do these look like? What are the challenges? And what can I do to help? What can we discuss, find reasons to try to change? And so set achievable goals. A different talk, a different time, but SMART goals are really important in all this, that those are important for your achievable goals, but that's a different talk another time. Nutritional counseling. So we're not just prescribing a diet, we're not telling them what to eat, but again, talking about what changes in eating might help your glucose levels. So again, that gives you a chance to explore some of the things they're already doing. You need a history. We got to understand where they're coming from. So what are some changes in eating might help your glucose level? Well, every morning I'm in a rush and I just grab a bagel and that's all I have. And so, okay, you're eating nothing but bread for breakfast. And then you're high all morning. All right. Well, let's talk about what can we do to that. And so we're always talking about adding a protein and fat to it, or trying to substitute here. What else do you like? What else is fast? And I understand you're busy. So what can we use with that? And now medication adherence. Again, this is one of those things that MI has been used for a long time, and something that we do have a lot of challenges with in diabetes, that we're giving medicines that people just don't necessarily want to take. We're giving a lot of shots and people don't like those. It sounds like remembering insulin doses is tough on busy mornings. We're going to collaborate to develop realistic strategies. Do you spend 5 minutes in drop-off line at the school? Okay, well, we have 5 minutes for sitting in the car every morning. Let's make that insulin time. When you see that specific stop sign, we're going to talk about it. Being creative with that, finding out where is that time in your morning that you can try to add it. So let's be a little more specific now. So a 25-year-old with fluctuating glucose and low motivation. What do you enjoy about the times your numbers are in range? We're focusing on that change talk. We're finding that motivation of what's good to them. Well, I feel more energetic and focused. Okay, well, you're finding that intrinsic motivators. What's important to them? Doing well in school, doing well at a job, doing well in sports, all of those, being energetic and focused sounds pretty important. And it's nice to reflect that back, the positive stuff. It's a little more enjoyable. All right, so we have somebody with type 2, and here talking about weight management, and I've tried diets and nothing works. We've got some of that sustained talk going. But you can reflect it back and try to redirect a little. You've made many efforts. What's one thing that's helped you in the past? And they might, again, just the sustained talk, none of it worked. Tell me about some of the different things you've tried, and continue to ask those open-end questions. Try to tease apart that more. And we know one question doesn't always get it there, but asking again, that non-judgmental, that open-ended, to help them find strength and autonomy in it. What have they done? So it's got to have some benefits, right? We're going to put in the effort to learn this. Improves glycemic control. We'll get into some studies that talk about that a little bit more. But generally, yes. Enhances medication adherence. That's been well studied, well established across many different diseases, and why it's used and continuing to be used for more different diseases. Increases patient satisfaction. As we said, people like to be heard, like to be seen. And we know patient satisfaction scores are important to us, or important to the systems we work in. And supports sustained behavior change. That in long-term follow-up studies, they see that the changes that are brought about are sustained long-term because we continue to give that patient intrinsic motivation. All right, so that A1C piece, I left a little bit of a hanger for y'all. In the oldest of the 3 meta-analyses I'll share with analysis, sure. In 2005, in a session of 15 minutes, MI was found to be effective. In further follow-up sessions, it was found to be effective. Our appointments are all less than 15 minutes, or at least 15 minutes. We can fit this into our visits. The first steps are asking open-ended questions. We're getting our subjective information. We're going to affirm, and then we're going to reflect, and we're going to help them develop their own plan. So we're still achieving all the things we need to do in our visit. We're just reframing the order or kind of the way we're concocting it, rather than that classic just SOAP format. But let them drive the plan. So 15 minutes is enough to be effective. Following up, we do that. Diabetes is long-term, makes it more effective. And it did find that there was statistical and clinical relevance in BMI improvements, although it didn't show improvements in A1C. So here is more of the data behind it there. So you can see body mass index did have statistical significance. Cholesterol had statistical significance, and so did this study was looking at drinking as well, and it had statistical significance with that, which we well know that this is good for addiction medicine. All right, these next two studies are a little more promising with A1C. So this one from 2019 is again another systematic review. So we're looking at multiple studies, and they did have improvements in blood sugar monitoring, which we know there's a great correlation in that. The more data you have, the more you understand the trends, better you can control it. And so they did see improvements in A1C. In this study, there was a bit of concerns about controlling for confounding factors, that they didn't do a great job on a lot of those other patient pieces. So here's some more of that review of the data. So each one of these shows that they had statistically significant decreases in A1C. So that first one decreased from 10.8 to 9.7%. And that was over 6 months of follow-up. And the next one from 1 to 2 years follow-up, the A1C was lower in the MI groups. I didn't give a specific number. Again, in the next one, lower by about 0.5%. And then the last one, it was lower by almost 2%. All right, and our last study that I brought up is the newest of them from 2020. And again, they showed significant differences in A1C. This one was also looking at depression scores and didn't find a statistically significant difference in those. And so here is their data pulled from it. And so some of the studies, 3 of them you can see don't have significance, but the 2 that do were enough to pull the data and call it statistically significant. I think most importantly of it all, though, we know it has a lot of importance in medication adherence. It has a lot of importance in lifestyle management, and those all factor into diabetes care. And if we're taking our medicines, then A1C is going to reflect what that medicine is capable of. You know, if their medicine is metformin, a GLP-1, insulin, A1C differences are going to reflect that if they're taking it more consistently. And then also it's going to be because they want to do it. And so they're going to be more likely to stick with it rather than just because we scared them today, they'll stick with it a week and then not do it anymore. But using brief MI, consistent conversations. So each time we're visiting, as that first meta-analysis said, strengthens the efficacy of it. Incorporating it into our follow-up visits, document the patient's motivations and goals. We like to know what's important to our patient. We ask them about it every time. So include it in there that you said you wanted to start exercising more because you feel like it's hard to have a conversation when you're walking with somebody. At the next visit, how's it been? Have you noticed that you've been able to have more chats while you're talking and walking? Has that been getting easier? Has that made any difference? Is it still the same? And checking in about that, helping them to continue to understand that motivation and reinforce their autonomy. You know, what was important 6 months ago in the middle of winter may not be important in the summer. Okay, well, what's important now in the summer? You're allowed to choose. You can change your goals. And continue to celebrate those incremental successes. So, you know, A1C came down 0.5%. We went from 11 to 10.5. We're making progress. We're moving. Let's celebrate that. You know what? We got a ways to go, but we're on our path. So here are my references, and here is the code for today. Dr. Watson. Thank you.
Question.
Please.
What do you do when motivational interviewing failed? You're so positive. I love that.
Tell me what you mean by failing.
Diabetes has poor adherence, and they are not even in the pre-contemplated stage,
Mhm.
right, of change. We're in the position where there's still, they need this medication, right?
Mhm.
Stay out of the hospital, so it fails, and yet we have to end the visit with something in place where there's a reasonable expectation that the patient is going to get medication.
Mhm.
Maybe it's a lesser amount, but enough to keep them out of the hospital and stay. I don't know,
Yeah.
how do you end on a positive note when you're trying to be responsive to them and they are not giving you anything back? It always feels bad.
Mhm. So, yeah, that's it hasn't worked yet. You're using sustained talk. It hasn't worked yet. But also, I mean, it is a little different in the we have to respect some level of autonomy, but pediatrics is a little different where it's if you don't do this, CPS is going to get involved kind of thing. And maybe that is the intrinsic motivator, or again, something on paper somewhere that it hasn't worked yet. They haven't found their own reason to motivate yet. Yeah, yes. But that's pre-contemplation. It's just they're not ready to change yet. They're not gonna change. And yeah. Mm-hmm. Yeah.
So does it require the individual seeing the same provider all the time? Or can it be, you need to have sort of a one?
It is built a lot on rapport, so you'd have probably more success following with the same person. But if you're documenting well and including their reasons they want to change, what's important to them, the conversation had, then there is some room to pick up with it. Mhm.
That someone else.
I don't know of anything being built into Epic, but I imagine creating a dot phrase wouldn't be terribly complicated, and creating a few lists that say, you know, what are their things they're interested in changing, what are their reasons for change, what's been difficult about changing, and then listing out some goals and being specific in those goals. And what I'll often do with those goals is I'll include them in my plan, but also copy and paste them into the wrap up. And so the patient's getting those goals and they have them in writing that this was your goal, this is something you created, and I'm writing it down in my plan, because why am I recreating my plan when my plan is our plan?
In Dayton, we had actually motivational interviewing. It's like, what stage are they currently in? What is the next step? What has been discussed thus far? I have like simple options that you can choose. That way, it's like that adolescent off about town. It's a good point.
Yeah.
You build that rapport, but then you never see them again. Are you really making an effective?
15 minutes is effective.
Any questions from chat?
No, I don't see any in the chat.
You can't even look at all the downloads in 15 minutes.
You would be patient are you infected the night before.
Wow.
And then you come with it.
Oh my God.
The preparation is almost like.
Yeah.
Jeez.
That's why it's hard to, but then you're doing it in emails many times, back and forth.
Mm-hmm.
And what you said words, like if you hold on and sort of,
Mm-hmm.
your support.
Yeah.
After 3-4 years, suddenly they come back and they start meeting change. It's like now they're rushing us to help and do everything. It's like, wait a minute, it took 3 years and now in 6 months, everything, which is good.
Yeah.
I think that's a kind of support helps because some people,
That's
for them to come to the realization or.
We want you all to work very hard, so by the time they come to us, they're all.
And they never go
We
to
try.
like people to be
We keep them so long that they.
I do feel like when I have like follow up with the same stubborn teenager, like eventually they realize, oh, this person is not going away, they're still supporting
Yeah.
me. And I do feel like I chip away a little bit, over time, and get them to buy in a little bit more. And I have seen people, come to the realization,
Mm-hmm.
make it to the other end of that, which is really cool.
Yeah, we had, with the nursing school, a few years ago, I think it was pre-pandemic. I did a study with using the apps, the motivational apps. Where we had engineering, computer engineering, those guys that share with the patient. So she was, I think, nursing school associated, she moved to class and said, we published that by one of the nursing. That was interesting. Of course, now there's so many apps and so many things. We just need more time in that.
Yeah.
I know in seeing adolescent patients and we talked about that and what came out of your appointment, they're like, oh, they just try to scare me. Oh, how do they do that? Oh, I'm gonna lose, have amputation, I'm gonna lose my eyesight, my kidneys. Like, what do you think about that? They're just trying to get me to do what they want me to do. So how did that, it just makes me mad. Like,
Mm-hmm.
but I think, I use motivational interviewing a lot, just because I think it gives me more information of how to navigate, and also too, that they feel interested in, they feel heard. I wonder, and I know you've, utilized this some in your practice. What do you, what's your experience in using it in practice? Does it take more time? Is it more challenging? Like what's been your experience?
I feel like it doesn't take more time necessarily because the people that do want to make changes, you do end up spending a little more time with them anyway because they already have a lot of questions, are really engaged. And so you're using this and building it into their goals. And the people not as interested in change, you're getting into that a little bit. And I feel like for the most part, able to respect that somewhat of like, all right, you're not ready for that, but just getting into this idea of what is important to you. And okay, well, let's try to do one small thing that is important to you. What's one part with that? So to the time question, I feel like earlier on took longer. As I do it more, getting more efficient, because I'm also building it in of, like I said, getting a lot of my subjective information and doing plans during that period and tying them together rather than thinking of them as these separate events that occur.